welcome everyone, and congratulations on completing or almost completing your remote meeting today. The fact that it is remote is because of what's in front of us right there, and that is the COVID virus, which we've all had to adapt to, adjust to, and live with for the last 9 months. So I know you're familiar with COVID, so I'm not going to spend a lot of time on some issues, but I thought it would be helpful to leaf through a couple of areas related to COVID. So I wanted to show this slide to say that this virus shown on the left is a very fragile virus. It doesn't take much to injure this virus. Drying out, alcohol, bleach, just a detergent or soap will kill this virus easily. Very fragile, very thin membrane. It dries out easily. It doesn't last long. And you can see it has nothing to swim or get anywhere to us. So it has no way of actually really moving from individual to individual unless we convey it in a moisture droplet large enough to keep it moist the entire time. Very, very sensitive to sunlight, outside things as well. Now, despite the fact that it's a very fragile virus, it's obviously taken off and it's got unique features that make it highly likely to be infectious. And who does it infect? Showing on this slide are the underlying conditions on the top that were associated with the initial cases of COVID hospitalization, showing that high blood pressure, obesity, chronic lung disease, diabetes, and cardiovascular disease all were significantly increased, especially in most cases when you get older in the prevalence of this disease or in the patients who were hospitalized. So certainly it hits or attacks preferentially people with chronic underlying disease, just what the Chronic Coalition has been dealing with for years. So it does attack chronic conditions specifically with a higher, in fact, severity of disease, resulting in more being in an ICU with chronic conditions, more having to be ventilated, and more individuals with chronic disease do not survive the virus infection. Why is that? Well, we think it is because they have some existing pathology, making it easier for the virus to invade. Two is they may have a reduced immune response, meaning the virus has less resistance when it enters the body. And it's possible that it may trigger the virus an over-aggressive immune system in the later stages with cytokine surges that could lead to further tissue damage, which could increase the severity of the disease in these cases. So we're all aware of the fact that the acute infection gives us lots of symptoms shown on the left, from headache, nausea, cough, fatigue, GI effects, and muscle aches. And on the right, it infects or affects almost every organ in the body from head to toes. This virus has influence as it enters many of these tissues, and the inflammatory and cytokine surge affects almost all of the tissues shown here. So it is very pervasive throughout the system. With acute infection, the two most common problems that we incur are on the top in the lungs, where it leads to actually invasion of the lung tissue. That can create problems. And often there's an immune response later stages of the virus after about 5 to 8 days, where we now get inflammatory activity. And sometimes an over-aggressive inflammatory reaction in the lungs can produce more lung damage than the actual virus did for that. On the bottom is showed cardiovascular effects, and cardiovascular effects can be associated because of loss of oxygen or hypoxia, damage to the actual muscle cells of the heart, damage to the actual myocardial cells as it permeates into those cells. The difficulty in perfusing through vascular chambers or vascular vessels that are damaged, as well as a propensity to develop blood clots, which could block off arteries and can literally lead to myocardial infarctions and other things. And lastly, on the right is the increased inflammatory response, which can lead to a myocarditis or uncontrolled inflammation throughout the heart. Both the lungs and the heart, when they're involved, increase the severity of the disease, increase the chance of mortality with this disease. Now, what we've described so far is the acute infection shown on the left side, which can vary from mild or no symptoms at all the way to critical symptoms requiring ICU involvement at that time. So that typically evolves over a period of several weeks. What we now realize that in addition to the acute infection, on the right, there's a significant amount of what is now termed post-acute infection from COVID. Now, you've heard a term earlier today from an individual that this is the, quote, long hauler's disease. These are symptoms, signs, and findings that don't go away after 3 weeks or after you recover from the initial acute infection. We believe that long haulers probably have significant organ dysfunction, and their symptoms are not just made up. These are real symptoms because we have evidence that there is, in fact, lasting organ dysfunction and pathology associated with post-acute infection. How often does post-acute infection occur? Fairly commonly. On the right, we can see post-acute infection was seen in up to 50% of individuals who had the initial infection. So a significant number, and as many as half of the individuals who recover from an acute infection may have lasting sequelae from the COVID infection. On the left, you can see the acute COVID phase has symptoms of fatigue, dyspnea, and joint pain, etc., as we look at the bars going to the left in black. On the right side of the bar graph in gray is the post-COVID follow-up. You see post-COVID disease produces almost as much fatigue, dyspnea, myalgias, as does the acute. Somewhat less, but significantly present at that time. So we are introducing now two diseases. One is acute COVID infection, which is seen with symptoms and signs on the left. And the second is in about as many as half of these patients, post-COVID-19 leads to further symptoms, so-called long hauler, and it can occur in as many as 50% of those individuals. This is now a new, or will be a new, chronic disease that we've just introduced with this virus. So the most severe later sequelae are shown here. So cardiac is certainly an initial acute infection where you have injury, myocarditis, heart attacks, cardiogenic shock, and thrombosis. Post-acute gives not exactly the same, but you can get significant amounts of inflammation, myocarditis, and importantly, myocardial fibrosis or scar. And this myocardial fibrosis or scar, as a result of the infection, does not simply melt away once you recover from the disease. We have evidence from other diseases that this may be lasting fibrosis and scar, lead to problems in relaxation of the heart and other problems. It may also lead to arrhythmias from the fibrosis that persist. And obviously there can be damage to the myocytes, the muscle fibers of the heart, leading to long-term cardiomyopathy in the post-acute infection phase. The damages of the heart are both from the virus directly entering into the muscle cells of the heart, shown on the upper left, and the virus actually enters and injures the muscle cell directly. In addition to that, there can be indirect damage from the inflammatory response trying to fight off the virus. And that inflammatory response releases a lot of cytokines, which can have direct damage to both the vessels of the heart and the muscle cells as well. And these, in the end, can lead to problems such as fibrosis that I said that does not resolve quickly and may last forever in these individuals, leading to cardiomyopathy, fibrosis, and significant problems. So how often does this occur? Well, in some of the trials, so this was the first trial that looked at late or post-acute problems in COVID in Germany. And what you see here is in 100 patients who recovered, and they're more than 2 months out from their COVID diagnosis, and they've recovered and they had pretty much mild symptoms. You can see cardiac involvement was seen in 78% of those with ongoing inflammation in the heart in 60% of these people, even though they thought they were okay and had recovered from the disease. So this duration is relatively prevalent in individuals, even though they feel that they have recovered from the disease in this situation. So these were straightforward patients who came in. The next series shown here is individuals who had also long haul evidence of imaging abnormalities in their heart, but they were 26 competitive college athletes, probably in much better shape than anyone on this call right now. They were in excellent shape. They didn't have severe symptoms. They were not hospitalized, but yet on the right, we see that 46%, almost half of these people, had evidence of myocarditis or myocardial injury by imaging when they were looked at after the procedure or after the initial infection, anywhere from 12 to 53 days later. So even in young, healthy, athletic individuals, we see residual damage from the initial COVID infection. And these persistent cardiac abnormalities are not just in the elderly or the very sick or those with concomitant disease. They also occur in people without any prior existing chronic disease for that. So the abnormalities in the heart are significant for post-acute infection, in the lungs as well. So acute infection or manifestation shown on the top gives you pneumonia, ARDS, and requires people to be on ventilators and oxygen for that. That is an acute pneumonia that people will, quote, recover from and be able to be discharged from the hospital. But what they leave with is post-acute manifestations. You can see lower down that 53% of the individuals who had the initial pulmonary involvement now have reduced muscle strength, reduced oxygen perfusion or CO perfusion in their lungs, reduced ventilation, and have literally restrictive lung disease because of interstitial thickening and fibrosis. Now, we know from other types of diseases that once you get interstitial thickening and fibrosis, which 71% of these individuals had, it does not go away with other diseases. And we have no anti-fibrosis or medicine to resolve interstitial thickening and fibrosis. So we've got lasting problems in the lungs and lasting problems in the heart. And if you have both lasting problems in heart and lungs, there's going to be a significant decline in your ability to exercise and to do normal activities for that. So there is quite good evidence that long haulers have a real problem with post-acute infection sequelae. Now, it's not just heart and lungs. We see evidence of changes after the COVID infection that occur acutely and post-acute with neurologic function. And on the right are imaging studies that show clear abnormalities in individuals who have had COVID or recovered from COVID, which appear to be lasting at this point out to 12 months. We don't know beyond that because we have not had any patients to follow for longer than 12 months at this point in time. These lead to all kinds of CNS problems and you may realize that there is complaints of individuals who are long haulers of brain fog and other things. And there does appear to be imaging evidence to back up that their neurologic function is not normal and does not return completely to normal after in the post-acute infection period. It can also affect the kidneys in the acute manifestation. About a third of individuals will have problems with kidney function. And we know that after they recover from that there can be prolonged kidney dysfunction in the post-acute phase, with about 37% of patients not requiring dialysis to have continued kidney dysfunction. So it's a hit to the kidneys as well. And in about a third of cases, that kidney does not return to normal as long as we followed it. Is it just in adults or people in nursing homes? No. It can affect younger people, middle-aged people, and here it can affect children as well. And what you see here is a rare but severe problem that we have seen with multi-system inflammatory syndrome in children and in adults, where there is this inflammatory process that is ongoing. And this is after recovering these kids from their initial COVID infection. The systemic inflammatory reaction occurs afterwards, after they've recovered, and is certainly in the post-acute phase and can lead to serious complications and significant problems in these children that we don't know how long they'll last. They may lead to coronary artery aneurysms. They may lead to other problems. And we don't yet understand what needs to be for treatment in these individuals at this time. But even children are not immune from the ravages of this disease. So what do we do for this disease? Well, there are treatment options. First of all, we very early on figured out how this virus was working. On the upper left corner is the virus as it enters into the cell. And when it enters into the cell, this brings only instructions as to how to construct a virus. And those instructions are relayed to your human cell. And it is your human cell that makes or manufactures all of the virus products and allows this virus to replicate. The virus message contains only instructions or mRNA inside it. It cannot make anything by itself. It requires your cells to manufacture and replicate itself. Because of the process that is fairly involved in replication, on the right, I've shown 7 steps that are required for this virus to enter a cell, replicate, and then be released from the cell. Each of those 7 steps has a specific way that we could interrupt one of those processes. And if we interrupt any of those steps, we could in fact not allow the virus to replicate at that time. So one interruption, one step is a treatment protocol for it. And we've developed, in fact, therapies for each of those 7 areas to reduce replication with the virus. On the bottom here is shown some of the ways that we've got of, in fact, reducing or slowing or eliminating the replication of the virus. The first is blockage of entry. And blockage of entry on the bottom is often focused on the spike that sits on the outside of the virus. And by developing antibodies that attach to the spike and don't allow it to contact and enter the cell, we can in fact avoid the virus actually entering into the cell. So blockage of entry therapies are shown on the left bottom. Then going to the right, we've also found medicines to block the replication of it. Shown there first is remdesivir, which we used back in February of this year, started using it with some benefit to the patients, and it reduces the days in the ICU for individuals by slowing down or blocking the replication of the virus. Farther to the right, we've found agents that boost the innate immune response, and those are in trials right now. And farther to the right is further agents are being looked at to enhance the innate immunity of our body so that we can, in fact, resist this viral infection. Remember on top, the virus is using our own cellular tissues to develop a manufacturing process it cannot do by itself so that it can replicate the virus and release it. So the therapies that we have talked about just now are being investigated in clinical trials. Some have received emergency approval, but have not been totally investigated. Remdesivir on the top is one of the more promising ones. But as I said, the best it does is shortens your time in the ICU by a day or 2 or 3. It does not cure the disease. The other clinical trials are under investigation, and so far, blocking viral replication has promise, but there is no curative trials that have shown removal of the virus in these trials. The next set of trials shown here on the top, these are trials that prevent entry into the cells of the virus. And these have been tried and are clinically being used and evaluated at this time. And there sort of is mixed data that they may benefit or not benefit individuals. We'll need to spend more time looking at the results of these individuals to know for sure. On the bottom are trials that try to reduce the hyperimmune response in individuals. So the initial infection with the virus is a viral infection, and the damage is caused by the virus. But after about day 7 or 10, the results of the virus infection lead to a hyperimmune response, which can lead to further damage. So suppressing that hyperimmune response in the trials shown on the bottom here are being investigated. And at this point, it's mixed results. We do know that steroids or high-dose dexamethasone has been apparently effective in reducing at least the hyperimmune system and may prevent some of the late damage associated with the acute infection for this. But since we have mixed benefit and modest at best with treatment of the actual virus infection, the best way and our best effort has been pushed over to develop an effective vaccine virus for COVID-19. So on the left, you can see the old way of developing a vaccine, and that was to get a weakened virus growing, kill the virus, or get pieces of it and inject them later on. This process for vaccination, which we've used effectively for lots of other viruses, takes several years to develop. You have to get the virus growing in a model, then you have to effectively weaken it, then you have to test it, and it's years to get that virus approved. On the bottom right, you can see that a new technique has been used for this virus because we understand a lot more about viruses and genetic engineering of viruses. And what we can see here is that we quickly, after this virus propagated, found out the exact DNA or mRNA sequence in the virus, the instructions, and we quickly determined that not only what the instructions were, but what they were coding for on the actual final virus capsule. And because of that, we could identify items that were targets for attack. And the first target that was identified was that spike that sits around the edge of the coronavirus. And we could identify the mRNA segment of the code of the instructions that actually coded for that spike. And therefore, the idea was, if we can code just for that spike, maybe we can get an immune response to it. So to envelop the mRNA for just the spike, we can do it either in a DNA plasmid. We can, in the middle bottom, embed it in an RNA lipid, which is what we'll talk about for the current Pfizer and Regeneron vaccines. Or we can, in what we've done before, place it in a relatively benign adenovirus, that mRNA information. That adenovirus then infects the body through vaccination and carries that RNA into it that can be used to generate spike protein. So the process that we developed initially was we identified the actual mRNA back in February. We had that. We had the sequence of it, which can be done in several days. It's amazing how fast you can come up with it. We used it to, in fact, inject the possible vaccines into primates and tested them first, small animals, then primates. And once that seemed to be effective and generate antibodies, the idea was to move into human trials shown on the bottom. Human trials go through phase 1, phase 2, and phase 3. And currently, 6 of these proposals are in the phase 3 or have completed phase 3 trials for it. And now we're moving to the next step, which is production of these vaccines. So here are the 6 vaccines currently available and that have gone either to phase 3 testing or completed phase 3 testing. Now, the virus is shown on the left. And again, we're trying to target those spikes, those little points that are sticking out from the edge of the virus, because those are things that are first encountered by our cells in our blood when this virus is around. And what we're trying to do is to develop antibodies from our cells that would directly attack those spikes. And if we attack and cover those spikes can no longer attach and enter any of our susceptible cells at that point. So we're going to try to manufacture antibodies specifically to the spike as our first guess at an effective vaccine. So on the bottom, it shows that there is mRNA or instructions that code only for the spike as far as a segment. Now, this is a small stretch or segment in a long RNA strand, but this is the one that actually codes for the manufacture of the protein that constitutes the spike, which is the entry for the virus into the cell. That RNA will injected into any of our cells can also be used to generate the spike protein, but nothing else, because there's no other coding information for the rest of the body or the internal guts or the RNA of the virus. So it's only going to code for the spike protein. So on the bottom, you can see the currently approved in Europe Pfizer BNT virus, in fact, produces RNA that codes for the spike protein in our own cells. The spike protein, if seen to our immune system, may generate antibodies, which then can be used to attack a subsequent or later infection by the actual virus. In the middle chain, you see that the AstraZeneca and Janssen vaccines, look at injecting a small segment of code, mRNA, directly into a adenovirus. The adenovirus goes in and is by itself enters the cell of our body, but brings that RNA information to generate a spike protein that again is used to, in fact, stimulate our immune system. And on the top, the Novavax and Sanofi vaccines say, well, we're not going to use the body to generate those spikes. We're going to make them in the lab, make millions or billions of them, and then inject the patients with so many spike proteins that it has to activate their immune system. So here is on the slide is what I would call a fake virus. If you've said this virus is fake, well, this is the only fake one that we're aware of. It is a manufactured fake virus. So there's a shell around it, but not the corona shell, obviously. There's RNA inside, but only a small segment of the RNA for the virus. So this is a totally defective agent because it has only it can only generate spikes in the body, nothing else of the virus, and has a completely different surface for that. So these two are suspended in a lipid nanoparticle that is similar to, but not identical to the coronavirus shell, and allows it to interact with the cell. And if we inject this into your arm, this nanoparticle will migrate into the muscle cells of your body, and then release the RNA, which is an instruction to your cells to start making spike protein, but spike protein only at that time. So here is a drawing showing the spike, the nanoparticle coming in on the left, entering into the cell, releasing a limited code information for just the spike, and your body, your cellular metabolism, endoplasmic reticulum and Golgi apparatus goes to work manufacturing just the spike protein, which is then released and displayed on the edge of the cell membrane enough that your immune system can recognize it and perhaps target it for antibodies at that point in time. So just like the virus entered the cell, used your cells for producing the virus, we're using the same mechanism. We're using a nanoparticle to go into the cell, and your body is going to make the spike proteins that are going to stimulate the development of antibodies in you as a patient for that. Now, these tests have been done in perhaps about 100,000 individuals. So the testing of these vaccines has widely been revealed in individuals. About 100,000 people may have been exposed to this. On the left, all ages have been done for adults, but not children at this point in time, but a significant number of older people have been done. On the right shows for one of the vaccines, the comorbidities in individuals. 17% of the people in this trial had chronic disease. Chronic disease consisted of diabetes, severe obesity, significant cardiac disease, chronic lung disease, or liver disease. So it's not as high as the general population, because perhaps about half of our general population may have some chronic condition, but at least a significant minority, 17% of the individuals in the trial, had chronic disease as a comorbidity. So it's been tested in those. So we do know that in those significant comorbid diseases, there has been testing of this particular vaccine. Who has been missing? Well, there's very few individuals in each of these trials who were pregnant for that. So we don't have good information yet in pregnancy as well as for the fetus at this point. And the other group that was not included is individuals who have history of hyperallergic reaction to various shots or other antigens. And so we have not really tested those individuals as well. But we do have a fair smattering of chronic disease that has already undergone testing with this vaccine. So what is the vaccine results? Shown here on the left is efficacy. If we look at the two RNA vaccines from Pfizer and Regeneron on the left, we see they are fairly beneficial. The first dose gives us about 55% protection from getting this virus. And if you receive the second dose 3 to 4 weeks later, after that second dose, you're up to 95% protected. So this is very good protection. If we look at typical vaccines, this is as good as or better than many of our vaccines that are available today. So this is great news for efficacy. And because of that, the Pfizer vaccine has been approved in UK and Canada as of today and is on the agenda for discussion tomorrow for the US FDA. And I anticipate it will probably be approved by Thursday or Friday of this week in the US as well, based on the information that I've seen. Now that's efficacy. Anything that is given as a medicine has efficacy and safety issues. To the right is the safety issues with this particular vaccine. And what we see, this is for the Regeneron vaccine, is the first column of bars is going to be after vaccination 1, what are your symptoms? And this column to the right, farther to the right, is after vaccination 2. You can see the column of vaccination 1, that there are some side effects associated with it, mostly local in the arm and pain associated with it. But going to the right, after vaccination 2, you still have those effects locally in the arm, but now you're left with a number of systemic effects. Significant would be arthralgia, fatigue, fever, and almost half of the individuals will have some level of symptoms from this. So this vaccine is not something where you get it and you walk home and you never know you got it. Within 24 to 36 hours, you're probably going to be symptomatic from this vaccine. And when you get it, you probably will not want to go to work or do things for the next 24 to 36 hours from it. You may want to go home, sleep, and take some Tylenol for fever. And you're going through a great stimulation of your immune system, and you're going to feel the effects of it. So it's not totally innocuous for that. In addition, I said earlier that we eliminated individuals with hyperactive allergic response in the initial group. And now that it's been administered to general public in UK, there are now 2 cases of a significant allergic reaction in healthcare providers for it. So if you have a history of severe vaccine or allergy reactions or anaphylaxis, then you need to talk to your provider before getting this vaccination, because we're going to be stimulating an immune system that may be a hyperimmune trigger in a particular patient. Those individuals have to talk to their healthcare providers and have available things for anaphylaxis, including epinephrine injections under a monitored site in that situation, all under the care, supervision, and recommendation of their healthcare professional. So now that we have a dose available for many, if not most individuals, that is effective and relatively safe and not perfectly tolerated, but what is 24 or 36 hours of symptoms compared to having go to the hospital, ICU, or dying? Significant benefit. No one died in those trials for that, and it significantly reduced severe disease later on for them. So we have a great vaccine. I think it's optimistically even better than we thought that would be there. And we have about 20 million doses for the Pfizer vaccine right now. So what do we do? Well, it's great. We're going to start, and within several days, I think 2 or 3 days, we should have approval. And within 2 or 3 days after that, availability of the doses throughout the US for inoculation and vaccination. The problem is 20 million adults can be, because it requires 2 doses, can be injected. And there is about 200 million people who are high risk, high medical conditions, essential workers, healthcare workers, and people in nursing homes. So we have enough for 1/10 of the people who really need it now. So we're going to have to go into a problem. We have a great vaccine, but availability is not there. The other question is, this virus, like any other, does mutate. We've got about almost 200 mutations in the virus so far. And so we wanted to know right away whether those mutations would invalidate the vaccine, similar to what they do in influenza, where we have to be alert and change our vaccine every year to be ahead of the mutations. Fortunately, coronavirus is a relatively slow mutator, and therefore we know right now that the variants out there, which are changing, are still susceptible to the current virus vaccine that we have identified so far. But because of the fact that we have few doses, we're going to have to go into allocation phases. The CDC allocations and CDPH are shown here. They basically say, let's take high-risk people, more likely to be exposed and to succumb to the disease, and start with them. But remember, we only have 1 in 10 that we can vaccinate right now. It's being shipped out. Distribution is a little bit more complex than for influenza because of some of the cold requirements for this, but it is going to be shipped out within days to offices that have signed up for it, clinics, pharmacies. Steve Chen was on earlier and said that 90% of us live within 5 miles of a pharmacy. Well, it's going to hit chain and independent pharmacies, and they're working on that as well. That's a good way to get it. We've done well with influenza distribution and inoculation. I think I'm optimistic that we can do just as well with this because of the priority that we're facing, and we should be able to do this. Our problem right now is a limited number of doses that are available, and it's unlikely that we'll get more than about 1 million doses a day from here on out for the next 100 days. So it's going to take us a while before we can inoculate the vast proportion of people in the US or in the world. So when can we return to normal? Well, I've outlined here the treatment protocol for COVID-19. On the top, we can see treatment of the disease. There was some good benefit from remdesivir and corticosteroids outlined in red. Those have been positive, but the biggest benefit is a better standard of care for people on ventilators, where we've significantly improved our therapy now that we understand the disease much better for that. Those have been big improvements, and we've cut our mortality for COVID, acute COVID, by 50%, in half. Great benefit, but there's still so many patients coming in with it. That's not good enough. We need to go to the far lower right. Vaccines is our only light at the end of the tunnel, because we have modest treatment capability, and vaccines is what is going to get us through the end of the tunnel. And what we see here is in the center is COVID. And COVID right now is killing 1 person every 40 seconds. So I've shown for every slide that I've gone through so far, somebody has died for every slide in the US that I've shown so far. In the middle, we see the third wave of the pandemic is occurring. And it's just going up at this point in time, with already 15 million cases and 285,000 deaths. Somebody died while I've had this slide up so far for 40 seconds. On the left, you see our prior number one killer, cardiac or heart disease, killing someone every 37 seconds. COVID is about to take over as the number one killer in the US at this time and take over from heart disease for that, and clearly far ahead of stroke, which is shown on the right. So in conclusion, what do we have here? We look at the COVID-19 pandemic, the worst pandemic in 102 years. What we see is that COVID-19 is a very fragile but highly infectious virus. The protection measures we've used or developed are very effective. That is spacing, mask wearing, etc. But restrictions, testing and tracking are not always accepted and followed. And that's why it continues to, in fact, increase in numbers. The acute COVID infection, we're now in the third wave, will probably double the number of infections that we have now, double the number of hospitalizations, and we believe deaths will get close to 500,000 people in the US before we're through this tunnel. We have unfortunately thrown to the coalition a whole new chronic condition, which you were not aware of, which will probably affect about 1 million Californians, about 10 million Americans, and over 100 million people worldwide. That new chronic condition is right now termed post-COVID, post-acute COVID. The treatments for COVID have cut the mortality by 50%, which is pretty great, but not curative considering the increasing number of patients with this. And lastly, vaccines are effective and relatively safe, but we have extremely limited availability at this time. And for that reason, we can see the light at the end of the tunnel, but we're still a long ways from exiting that tunnel.